Hello, I'm Mark Weigel, Administrative Office Director for the West Virginia Office of Emergency Medical Services. This video was funded in whole through the Health Resources Service Administration EMS for Children State Partnership Grant. The intent of this video is to serve as an educational tool for EMS field providers and educators. In West Virginia, the pediatric patient makes up approximately 5% of all calls received by EMS field providers. The pediatric patient cannot be treated merely as a small adult, as their needs are very specialized. These specialized needs include basic equipment size, medication dosages, and the fact their bodies respond to medical conditions very differently from that of an adult. As such, the West Virginia Office of EMS for Children's program remains committed to ensuring children have access to appropriate health care in the pre-hospital setting. It is our belief the availability of pediatric education for the EMS field provider is a crucial component of this commitment. Thank you for taking the time to view this video and ensuring that the EMS system is best prepared to treat West Virginia's smallest patients.
Body substance isolation, or BSI. Gloves are the most common type of personal protective equipment, or PPE, utilized by rescuers. Participants in this video are utilizing gloves as a minimum standard to protect the rescuer from possible exposure to blood or body fluids. Actual patient care may require additional protective equipment such as a mask, eye protection, or gown. Patient assessment. Trauma.
BSI Scene Safe, Body Substance Isolation, PPE, Personal Protection Equipment. I'm going to ensure that my scene is safe, then I'm going to determine my mechanism of injury. Determine how many patients I have, consider additional help, and I'm going to go ahead and have my partner hold C-spine. Initial assessment. First, I'm going to form a general impression of my patient. Then I'm going to assess his level of consciousness. Sir, are you okay? Are you okay? I'm going to use the AVPU scale.
AVPU. A. Alert. V. Verbal. P. Pain. U. Unresponsive.
I'm going to determine the patient's chief complaint and treat any life threats. Then I'm going to open his airway using a modified jaw thrust. I'm going to look, listen, and feel, looking for any rise and fall in the chest, also feeling and listening for any breath sounds. At this point, I'm going to go ahead and put in some form of airway adjunct. Once I do this, I need to make sure that my patient is adequately being ventilated. Once again, looking for rise and fall in the chest. I'm going to assess my patient's circulation. I'm going to treat any immediate bleeding, also checking for a carotid pulse. At this time, I can go ahead and start to get my baseline set of vitals. If I have a carotid pulse, that lets me know that I have a BP of 60 palp. While I'm doing this, I'm also going to assess my patient's skin condition. Is he pink, warm, and dry? Is he cold and clammy? Is he diaphoretic? At this point, I'm going to determine priority of transport and determine if I'm going to do a rapid trauma assessment or a focused trauma assessment. We've determined that we're going to do a rapid trauma assessment, starting at the head and ending at the feet. I'm checking the head for any grading or crepitus, or DCAP BTLS.
DCAP BTLS. D. Deformities. C. Contusions. A. Abrasions. P. Punctures or penetrations. B. Burns. T. Tenderness. L. Lacerations. S. Swelling.
Working my way down the head, I'm checking the pupils for their reactivity to light and their size. Checking the face for any DCAP BTLS. Checking behind the ears for battle signs. Working my way to the neck, I'm checking for midline deviation, checking also for jugular vein distension, checking the chest for flail chest, equal rise and fall, or any type of sucking chest wound. Working my way to the abdomen, I'm going to palpate all 4 quadrants, checking for any rigidity, distension, or tenderness. Once I get to the pelvis, I'm pushing down and in, checking for any instability, grading, or crepitus. I'm going to check each leg individually, checking for any grading, crepitus, DCAP BTLS. Once I get to the feet, I'm going to check for any signs of motor sensory, Also checking a distal pulse. If I have a distal pulse, that lets me know that I have a BP of 90 palp. Coming over to this leg, assessing for the same thing. Any grading, crepitus, decap, BTLS. Checking my distal pulse and motor sensory here as well. Checking this arm for any decap, BTLS, and also my distal pulse again. Coming over to this side, checking once again for any obvious wounds or deformities, decap, BTLS, distal pulses, and motor sensory. We're now going to roll the patient in one unit, ensuring that we keep the spine straight.
1, 2, 3.
And now we're going to check the patient's spine, checking for any obvious wounds or deformities, any decap, BTLS. We're going to roll the patient onto the backboard to fully immobilize him.
1, 2, 3.
Now that we've got the patient in the back of the ambulance, we're going to continue our ongoing assessment, starting with another set of vitals. I'm going to determine what my patient's chief complaint is. Then I'm going to assess his airway, breathing, and circulation. Since this is a medical patient and I'm not suspecting any trauma at this time, I'm going to use a head tilt chin lift to open the airway. Once again, I'm going to look, listen, and feel, looking for any rise and fall in the chest, feeling and listening for any breath sounds. If I need to at this time, I'm going to put in an airway adjunct. And once I do that, I need to notice again for adequate rise and fall in the chest to make sure that my patient is getting the appropriate ventilations. I'm going to assess my patient's circulation, checking here for a carotid pulse. I can also go ahead and get a set of baseline vitals from here. If my patient has a carotid pulse, that lets me know he's got a BP of at least 60 palp. I'm also assessing my patient's skin, seeing if he's pink, warm, and dry, diaphoretic, cold, and clammy. I need to determine the priority for transport and also determine if I'm going to do a rapid or focused medical exam. We've determined that we're going to do a focused medical exam using the sample history.
Sample. S. Signs and symptoms. A. Allergies. M. Medications. P. Pertinent past history. L. Last oral intake. E. Events leading up to the incident.
Also using the OPQRST.
OPQRST. O. Onset. P. Provokes. Q. Quality. R. Radiation. S. Severity. T. Time.
I'm going to check my patient's initial vital signs and also determine which interventions are appropriate for my patient's chief complaints. After we've chosen the appropriate medication for our patient's chief complaint, we need to redo our initial assessment, reassess the patient's vitals to determine whether or not our interventions are working, and also recheck our focused examination.
Oral glucose administration. Take BSI precautions. Perform blood glucose check. Prepare glucometer and supplies. Cleanse the site. Lance the site. Apply blood test strip. Apply direct pressure to the site. Read the results. Determine appropriate indications for glucose administration. Assess patient's level of consciousness. Contact medical command if patient's condition persists. Confirm the expiration date on the oral glucose. Check the 5 rights of drug administration: right patient, right drug, right dose, right route, right time. Position the patient appropriately. Explain the procedure to the patient. Place the glucose between the cheek and gum. Recheck the patient's blood glucose within 5 minutes of administration. If there is no improvement, contact medical command. Request ALS backup, transport, and meet en route. Document the procedure. Nebulized medication administration. Take BSI precautions. Assess the patient's ability to use the nebulizer. Consult with medical command. Explain the procedure to the patient. Confirm that the patient has no allergies to the medication. Check the 5 rights of drug administration: right patient, right drug, right dose, right route, right time. Prepare the medication and nebulizer. Unscrew the lid of the nebulizer chamber. Add medication as directed. Reattach the lid. Fasten the T-tube to the nebulizer chamber. Connect the mouthpiece to the T-tube and the flex tube to the other end. Attach oxygen to the nebulizer. Confirm 8 to 10 liters per minute oxygen flow. Confirm the mist is coming out of the flex tube and the mouthpiece. Confirm the patient is sitting upright as much as possible. Administer medication to the patient. Instruct the patient to hold the nebulizer in their hand. Place firmly in the patient's mouth with lips sealed around the mouthpiece. Instruct the patient to breathe deeply and slowly. Confirm that all of the medication is tapped down from the sides of the chamber. Continue treatment until all of the medication is gone. Monitor the patient's condition and vital signs after administration. Document the procedure. Nitroglycerin administration. Take BSI precautions. Consult with medical command. Confirm the expiration date on the nitroglycerin. Confirm the patient has no allergies to the medication. Confirm the patient's systolic BP is above the required limit, 100 systolic. Check the 5 rights of drug administration: right patient, right drug, right dose, right route, right time. Place the patient in a comfortable position. Explain the possible side effects of nitroglycerin administration. Instruct the patient to place the tablet under tongue and allow it to dissolve. Recheck the patient's blood pressure within 3 minutes of administration. If the patient is still in pain, administer additional nitroglycerin per protocol and medical command direction. Document the procedure. Epinephrine autoinjector administration. Take BSI precautions. Consult with medical command. Explain the procedure to the patient. Confirm that the patient has no allergies to the medication. Check the 5 rights of drug administration: right patient, right drug, right dose, right route, right time. Remove cap from the autoinjector. Verbalize exposure to the thigh area. Place autoinjector on lateral thigh, midway between the patient's knee and thigh. Explain to the patient that they will feel a stick from the needle. In a smooth, firm fashion, push the injector until the click is heard. Hold the autoinjector against the thigh for 10 seconds. Dispose of the autoinjector in a sharps container. Monitor the patient's condition and vital signs after the administration. Document the procedure.
With an infant patient, there's 2 ways to do CPR. We can just use the 2-finger technique. Or we could use the 2-handed encircling technique if you have 2 rescuers. When placing an infant on an AED, the pad placement can be different from anterior to posterior.
The following is a LifePak 500 demonstration for any child ages 8 years old and older. If possible, utilize an AED that is adapted to pediatric use in infants and children, as these are designed with attenuators that reduce the energy delivered and have smaller pads designed for their chest size. It is recommended that emergency doses of 2 to 4 joules per kilogram for defibrillation of children. If an adult-sized AED is the only one available and the pads fit on the child's chest without touching each other, it is better to use the adult AED on the child or infant than to continue CPR without it.
One of the main differences in an adult electrode and a pediatric electrode is the attenuator. The purpose of the attenuator is to reduce the amount of electricity given to the patient. I have my BSI and also make sure that the scene is safe. Approach the patient, check for responsiveness. Hey, are you okay? Are you okay? I notice that he's unresponsive. Look for breathing, look, listen, and feel. No breathing, and then check for a pulse. No pulse. Go ahead and get the AED and help me with some ventilations. And immediately begin CPR. 30 compressions to 2 breaths. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 27, 28, 29, 30.
The AED has arrived.
Okay, you can go ahead and take over compressions and I'll operate the AED.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25,
Connect
26,
electrode.
27, 28, 29, 30.
Connect
19,
electrode.
20, 21, 22.
Push analyze.
All right, everybody clear? We're going to analyze.
Stand clear. Analyzing now. Stand clear. Shock advised.
All right, I'm clear, you're clear, everybody's clear?
The following is a LifePak 500 demonstration for any child ages 8 years old and older. If possible, utilize an AED that is adapted to pediatric use in infants and children, as these are designed with attenuators that reduce the energy delivered and have smaller pads designed for their chest size. It is recommended that emergency doses of 2 to 4 joules per kilogram for defibrillation of children. If an adult-sized AED is the only one available and the pads fit on the child's chest without touching each other, it is better to use the adult AED on the child or infant than to continue CPR without it.
Stand clear. Push to shock.
Shock. Okay, continue CPR.
Start CPR.
All right, I'm going to continue doing CPR for the next 2 minutes. While this is going on, maybe try to obtain a history from any family or bystanders that witnessed this. And also I'm going to place in a airway adjunct and supply 100% O2. While performing CPR on a small child, it may be necessary to use the heel of just one hand. Make sure we have our BSI and we're going to assure that the scene is safe. Go ahead and hold manual C-spine. Check for PMS. Can you feel this? Mm-hmm. Can you squeeze my hands? Good job. Can you feel this okay? Mm-hmm. Check for pulses. Can you wiggle your toes? Okay. Go ahead and apply the C-collar and continue to hold manual C-spine. While we're applying the C-collar, continue to hold manual C-spine. Okay, good. Now on your count, we'll roll him over on his side and place the board under.
All right, everybody ready? On 3, 1, 2, 3.
Before you roll him back onto the board, you want to check the backside for any injuries. Okay, and on your count, we'll flip him back down.
1, 2, 3.
Okay, and slide down on the count of 3,
1, 2, 3.
and then back up.
1, 2, 3.
Okay, now we'll fill any voids if necessary. This patient looks like he's all right. And we'll go ahead and secure the straps. Secure the torso first. Now we're going to apply the head blocks, and we'll continue to hold manual C-spine until these are secured to the board. I'm going to put this on his forehead, that way we don't tape his eyebrows or hair down. And secure that under the chin. And then secure the head. All right, now that we have him immobilized, we want to check the pulse motor sensory again. Can you feel this? Check for pulses. Can you squeeze my hands? Good job. Can you feel this? Good pulses there. Can you move your toes? Okay, good. So he has good PMS in all extremities. Now the patient is fully immobilized and we're ready for transport. The main difference with the adult and the pediatric board is in that the pediatric board, the notch is here for the head to fit down into better. That way the shoulders are elevated.
The PD-made child restraint systems is designed to safely transport the pediatric patient. Details regarding this device are as follows. A 3-restraint straps designed to attach quickly, easily, and securely. A fully adjusting 5-point harness system that fits each child firmly and provides safe control during transport. Securely holds children from 10 to 40 pounds. Rolls compactly, allowing for efficient storage and retrieval. Made from non-toxic vinyl that allows for ease of cleaning. EMS agency and EMS field personnel must review, understand, and follow the manufacturer's guidelines. Each EMS agency shall care for and maintain the device according to the manufacturer's guidelines. Spinal immobilization, seated patient. Ensure the scene is safe and all rescuers are wearing appropriate body substance isolation, or BSI. The following is a seated immobilization demonstration for an adolescent patient. Direct your assistant to place the head in a neutral inline position. Assess pulse motor sensory function, or PMS, in each extremity. Apply the appropriate cervical collar. Position the immobilization device behind the patient. Secure the device to the patient's torso in the following order. Torso. Elevate torso fixation and adjust as necessary. Legs. Apply the leg straps using special attention to pad the groin area. Head. Elevate and pad behind the patient's head and secure the patient's head to the device. Readjust all straps, ensuring they are a tight, snug fit. Reassess pulse motor sensory function, or PMS, in each extremity. Verbalize moving the patient to a longboard and prepare for transportation. Baseline vitals. Ensure the scene is safe and all rescuers are wearing appropriate body substance isolation, or BSI. Blood pressure palpation. The following table is an example of baseline vitals by age. Apply the blood pressure cuff 1 inch above and antecubital space, not over clothing. Ensure snug fit, center bladder over artery. Palpate radial or brachial artery. Inflate the cuff rapidly, at least 20 millimeters mercury above the point where pulse is lost. Slowly deflate the cuff. Blood pressure, auscultation. Apply blood pressure cuff 1 inch above the antecubital space, not cover clothing. Ensure snug fit, center bladder over artery. Hyperextend extremity and palpate brachial artery. Place diaphragm of stethoscope over brachial artery. Inflate cuff rapidly at least 20 millimeters above palpated pulse. Slowly deflate cuff. Record auscultated blood pressure. Margin ±4 millimeters mercury. Pulse. Palpate with 2 fingers, index and middle, over radial artery. Count palpitated pulse for a minimum of 30 seconds and multiply by 2. Assess the following: rate, rhythm, regular or irregular, quality, strong or weak. Report, record pulse findings, margin plus minus 4. Respirations. Observe rise and fall of the chest or abdomen. Count respiratory rate for at least 30 seconds and multiply times 2. Assess the following: rate, rhythm, regular or irregular, quality, shallow, deep, normal. Report, record respiration findings, margin plus minus 2. Skin signs. Assess the following: skin color. Observe the patient. Normal, cyanosis, jaundice, ashen, paleness, flushing. Skin temperature. Touch the patient. Normal, warm, cool, cold, hot. Skin moisture. Touch the patient. Normal, moist, diaphoretic. Bleeding control and shock management. Ensure the scene is safe and all rescuers are wearing appropriate body substance isolation, or BSI. Apply direct pressure to the wound. Assess the effectiveness of the intervention. If the wound continues to bleed, apply a pressure dressing to the wound. Assess the effectiveness of the intervention. If the wound continues to bleed, apply a tourniquet 2 inches proximal to the wound but not directly over a joint. Assess the effectiveness of the intervention. Document the time of the tourniquet application. If the patient exhibits signs of shock, such as pale, diaphoretic skin, and a weak, rapid pulse, take the following steps. Position the patient supine while elevating the feet 6 to 10 inches. Cover the patient with a blanket to prevent heat loss. Administer high concentrations of oxygen via non-rebreather. Prepare the patient for rapid transportation. Intravenous therapy. Ensure the scene is safe and all rescuers are wearing appropriate body substance isolation, or BSI. Check selected IV fluids for proper fluid, clarity, expiration date. Select the proper administration set. Connect the IV tubing to the IV bag. Prepare the administration set by filling the drip chamber and flushing the tube. Cuts or tears tape and selects appropriately sized catheter for venipuncture. Apply tourniquet. Palpate suitable vein. Cleans the site appropriately. insert catheter, note flashback, occludes the vein proximal to the catheter, remove the stylet, dispose of the needle in the proper container, connect the IV tubing to the catheter, release the tourniquet, run the IV fluid for a brief period to assure a patent line, secure the catheter, adjust the flow rate appropriately.